Ladies and gentlemen, please welcome our chairperson, Dr. Aksa Syuhada. Please, the time is yours.
Thank you, Dr. Yosi. Good morning, everybody. Everybody, please mute your microphone before we start the session. Good morning, everybody. Today must be our lucky day because we have Professor Cheng Ming in our session in this meeting. Professor Cheng is well recognized as a physiology lecturer who share his knowledge for many medical and dental institutions in Indonesia. He is graduated from BSc until PhD from the University of Liverpool in England. You can see his impressive CV in the monitor after this. Today, Professor Cheng will share his knowledge about blood pressure regulation. This activity is an integral part of physiology curriculum in our campus, so all of the second semester of the students must attend this meeting. Since we have a very limited time, let us start the lecture. Professor Cheng, are you ready?
Yes, thank you, Dr. Aksa.
Before we start your lecture, let me display your curriculum vitae in briefly. This is the brief curriculum vitae of Professor Dr. Cheng Ming. He completed all academic degrees from University of Liverpool in UK, and he published so many books, especially related to the education of physiology. So you can see the number of his publication, so many, very impressive. Yeah, I think we can figure out how great Professor Cheng is in this area of physiology. Professor Cheng, take your time. You have 50 minutes to deliver your presentation. Thank you.
Thank you, Dr. Aksa. So let me just start by sharing screen, and then, okay. Okay, yeah, as Dr. Aksa mentioned, I teach in the medical faculty, physiology, obviously, and also in the last Corona year, I've had the opportunity to talk to various medical students in several medical schools in Indonesia over Zoom session. So I'm very pleased that this morning I've the privilege to link up with the dental students in Airlangga, and I wasn't aware that we also have students, I presume, from Hasanuddin University also joining us for this session. So my contact with dental students also extends. My contact with dental students also involve the activity that we organized a couple of years ago, and this is the interdental physiology quiz. So physiology is the common factor that binds the dental and medical students. And so I just want to show one picture that I found in preparation for this talk. And this is actually in the Faculty of Medicine in University Malaya. And these are a group of Indonesian students that came for the friendly physiology competition. And at least 2 or 3 students, actually, they are your seniors in Airlangga. They may have already graduated. I think this girl here, I've forgotten the name. And the one in front is Hendra. I don't know whether he has just graduated. And the other 2 groups of students are from Malang, University of Brawijaya, and also from UI. So they came together for the physiology competition. And this was 4 years ago. We call this the IDPQ, Interdental Physiology Quiz. Yeah. So it is good to establish links again with students in Airlangga and also with Hasanuddin University. So let's get into the talk. So the title of this morning's talk is Neuroendocrine Regulation of Blood Pressure. So in a sense, we can look at physiology always from different perspective. So if you want a fuller title of this morning's talk, it would be neuroendocrine regulation of the integrated cardio-renal mechanism of blood pressure control. Because we will see in a short while that the role of the nerve and the hormones involves predominantly two systems. One is the cardiovascular system, obviously, but also it involves very importantly the renal system, because the renal system affects blood volume and that indirectly affects blood pressure. So let me start with the next slide by looking at the major hormones that are involved in blood pressure regulation. So I was told by the students in Ailanga that they've just finishing the cardiovascular block, and so I assume that's the same with students in Hasanuddin. And so this morning's talk in this short time will be a big picture. We used to call this the bird's eye view, big picture, or maybe you can use the word, since now you use drone's eye view of blood pressure regulation involving the neuroendocrine mechanism. So as I was thinking about, these are the major hormones we'll be talking about. And I think all students know that there are four major types of hormones: peptide, neurohormone, steroid hormone, and catecholamines. And these are just an example of each type of hormones that we will see are all involved in blood pressure regulation. And interestingly, I just looked at it again, and most of these molecules, humoral molecules, are small molecules. Adrenaline, steroid, antidiuretic hormone, which is a neurohormone, is only 9 amino acid, and angiotensin 2 is also very short. You can add actually to this list atrial natriuretic peptide, which is much longer, about 30 amino acid, and that is also involved in blood volume and blood pressure control. So interestingly, obviously, I looked at your teeth, our teeth, and there are 4 major types of teeth. Okay, so that fits in with the 4 major types of hormones, and I thought that the coincidence is quite interesting. This morning's talk will be slightly different from what you may be used to as students, because I've had the privilege over the last few months in giving talks to medical schools in Indonesia as well as in the Philippines to involve some of your classmates in giving a short introduction before I elaborate further. So the first point, and I will invite the 2 of the classmates to come on, is how does a rhythmic cardiac pump, the cardiac pump is not a constant pressure pump, it pumps and then it relaxes. So how does a rhythmic cardiac pump maintain a continuous flow to the tissue? In other words, there is no constant pumping. So how does the heart cardiovascular system maintain a continuous pressure, blood pressure, in order to supply a continuous flow to the tissue? So I'm very happy to invite now Patricia and Yasmin, who will come on and give us a bit of introduction.
Thank you, Prof. Cheng, for handing it over to us. Honorable professors, doctors, esteemed guests, and all of the fellow seniors and friends, greetings and a very good morning to all of us. I'm very pleased to be able to join in the introduction of this lecture. And today I am not alone in here. I am with my partner, Yasmin. Hello, Yasmin. Are you there?
Hi, Patricia. Yeah, I'm here. Are you
How are
ready?
you?
Yeah,
How are you today, Yasmin? I'm very
fine.
ready.
Yeah, okay.
So Yasmin, didn't you remember that last time when I called you when I asked about my physiology course when I need your help last time.
Yeah, I still remember about our conversation, and I think it's quite good if we share our conversation with our friends here today.
Yes, indeed. We were talking about that diastolic and systolic blood pressure, and I guess it's really interesting to be able to share it with our fellow classmates and the guests. So let's bring it on, Yasmin.
Yeah, okay.
Ada uang, Mama. Belum ngambil uang. Iya, Mama. Ini nggak ada anunya, Mama.
Hello, Yasmin. Good morning.
Hello Patricia, how are you? It's been a while since we are on the phone.
Oh, yes, sure, Yasmin. I have been quite busy on my studies lately, and currently I am working on my physiology course.
Wow, sounds great. Tell me about it.
Well, Yasmin, you know that this week my class will have a discussion with Prof. Cheng about blood pressure. But there are a few questions I have in mind, and I'm wondering if you have any idea about it. So my first question would be, how does a rhythmic cardiac pump maintain a continuous flow to the tissues?
Good question. I think when the ventricles relax and are not contracting, there must be a continuous pressure to maintain the flow to the cells.
Aha, I see. I remember this driving pressure during the ventricular relaxation is called the diastolic blood pressure, isn't it?
Yeah, true. By the way, Pat, maybe you know what generates this blood pressure during diastolic relaxation of ventricles when the intraventricular pressure is close to 0 mmHg.
Oh, so far that I remember, diastolic blood pressure is due to the elastic recoil of the aorta or the large arteries. During systole, when the ventricles contract, the ejected blood also stretches the elastic arteries.
Wow, that's cool. So while the ventricles top up and refill with blood during diastole, the elastic artery recoil provides the diastolic blood pressure, isn't it?
Yes, absolutely, Yasmin. Perhaps we can watch Prof. Cheng's lecture regarding the topic together.
Yeah,
Would you like to listen to it?
okay, sure.
Okay, thank you, Yasmin and Patricia, for that nice introduction. So let me continue and elaborate on this first point. Here we are. So this is the pressure profile curve that all of you should be familiar with. So on the x-axis, you have the various parts of the closed circulatory loop from the aorta, the left side of the heart, going down to the capillaries, the venules and veins, and then it arrives at the right atrium. And so, as we all know very well, the first part of the pressure profile is obviously pulsatile. You have the systolic blood pressure and the diastolic blood pressure. And so the way in which the cardiovascular system is still able to maintain a relatively constant mean arterial pressure to the rest of the circulation is, as the students explained, that the conduit or the channels, the blood vessel, they are not fixed, rigid structures, they are elastic. And so although the ventricles are relaxing during diastole, there is still the diastolic blood pressure because of the elastic recoil of the large arteries that maintain the continuous driving pressure for the blood flow. And so now when we reach the arteriole, you begin to see that the blood flow is more laminar, okay? And there's a sharp decline at the region of the arterioles. So this is obviously the main structure that we will talk about in a short while, because the arterioles are described as the resistance vessels in maintaining the blood pressure. And so you see a sharp decline in the blood pressure, because anywhere you get a region of high resistance, you will always see the greatest drop in the pressure. And in terms of the neuroendocrine control of blood pressure, so one of the first few points to make is that the arterioles are supplied by the sympathetic nerves, and they are vasoconstrictor nerves. And obviously the arterioles, being smooth muscle, they are also responsive to vasodilators as well as vasoconstrictor. Now I want to mention just 2 points here, which we will elaborate in a short while. And that is, we talked about an upstream effect and a downstream effect. So meaning that if you have a point of constriction and mainly at the arterioles, the upstream effect will always be to raise the pressure. And this happens when you increase the total peripheral resistance, the pressure increases. But downstream, there is a separate effect whereby the pressure always drops, okay, downstream, because of the high resistance here. And this will happen in the capillary. So we're going to talk about how the sympathetic activity to the arterioles by indirectly decreasing the capillary hydrostatic pressure also helps to maintain blood pressure. So that will be towards the end of this morning's talk. So I want to call now another 3 students who will elaborate slightly on the major, So this is the major equation that all students know or must know, and this is blood pressure is CO, cardiac output, times TPR. And these are determinants of blood pressure. And to elaborate on the fact that this basic relationship in cardiovascular physiology is actually derived from the simple flow pressure resistance of a single vessel. So let me welcome Ramadhani, Reina, and Josephine, who will talk a little bit about this.
Thank you so much for Professor Cheng involving us in this presentation today. I also wanted to give a warm good morning to the respected doctors and professors, also to my fellow friends. Representing my groups consisted of me, Reina and Isa, and then my 2 friends, Ramadhani Darmawan, also Josephine Serait. They probably wanted to give 1 or 2 words to say hello.
Hello everyone, good morning. I'm Ramadhani Darmawan.
Hello everyone, good morning. I'm Josephine Serait.
I'm gonna share screen because we have a video for the introduction in this topic.
Hey Reina, I noticed you changed your screensaver to a cardiovascular equation.
Yes, need to familiarize myself with this relationship between blood pressure, cardiac output, and total peripheral resistance, which blood pressure is cardiac output multiplied by total peripheral resistance.
It will help if you remember that the blood pressure equals cardiac output times total peripheral resistance equation is derived from the basic hemodynamics formula of flow equals pressure divided by resistance for a single blood vessel.
Okay, so the flow is pressure per resistance equation can be applied to the whole systemic cardiovascular circuit from left side to the right side of the heart.
Precisely, the flow become cardiac output, the pressure become the mean arterial pressure, and the R is the total peripheral resistance.
Thanks, I won't be needing this cardiovascular screensaver then. We'll change it to my boyfriend's pic.
Don't worry guys, after this, Professor Cheng will be explaining more about this.
Okay, thank you, Ramadhani, Reina, and Josephine for that introduction. So I hope that the students will appreciate how you come to derive this blood pressure equal to cardiac output times TPR. So logically, you can derive it from the flow equal to pressure over resistance, so that you don't need to memorize so much. Let me continue. So this is basically what the students have been talking about. So I'm also going to share my PowerPoint slide with all of you. So I will send it to Dr. Aksa and make it available to all of you students, so that you don't have to feel you need to copy in a hurry. Okay. So let me digress slightly. I'm of Chinese origin, and some of the Chinese characters for the structures in the body actually does interestingly represent the function. So this is a Chinese character. It looks like a Chinese character for heart in Chinese. So, and if you look at it, actually, it looks like a ventricle, okay? And this would represent the venous return, and this would represent the cardiac output. So this is the Chinese character for the heart. So let's go back to this basic equation. Blood pressure equal to cardiac output times total peripheral resistance. So we just made the first point that most of the total peripheral resistance is a function of the high resistance arteriole, which are innervated by sympathetic nerves as well as responsive to vasoactive agents in the body. So this represents the three types of muscles that are involved in blood pressure. So this is the smooth muscle arterioles, cardiac muscle, obviously, because of its activity in the heart rate as well as the stroke volume. And then this is obviously skeletal muscle. So in the next slide, I'm just going to remind students that your skeletal muscles are also involved in the overall control of blood pressure. And this is in maintaining a good venous return back to the heart. Because in the closed circulatory circuit, the venous return is equal to the cardiac output. So let me just remind you here that the skeletal muscle contraction pump actually contributes to a greater cardiac output, which obviously then contribute to the higher pressure, which is necessary when you are doing some physical activity. And so this is the skeletal muscle pump increasing the venous return, and then that also generates the greater cardiac output. This obviously has been described by Ernest Starling. This is Ernest Starling, and called the Starling's law or mechanism of the heart. Okay, so this is the picture. Now, in recent years, I've used a kind of an image or diagram to help students to organize small pieces of information. So the next slide shows you from one of my books. This is a triangle showing you the function of the sympathetic nerves, the main nerve that affects the heart rate, SA node, as well as the ventricles. Okay, and so we know that the cardiac sympathetic nerves will directly affect heart rate, will also directly affect the contractility, the ventricles. But in addition to that, the sympathetic nerves at the same time also increases the secretion of the catecholamines, primarily adrenaline, from the adrenal medulla. And so not only do you get a direct effect, but you also get an indirect effect through the increase in the catecholamines or the adrenaline. And the circulating adrenaline can then further enhance the increase in the heart rate as well as the increase in the contractility of the heart. So, so this whole system is sometimes called the sympatho-adrenal medullary axis. This is the first example of a neurohormonal regulation of blood pressure, direct effect on heart rate and stroke volume, and indirect effect through the same sympathetic nerves that stimulates the adrenal medulla. And I think we know that the effect on the heart is a beta effect, So this is the adrenergic beta action. And obviously, we just mentioned that the sympathetic nerves also affects the constriction of the arterioles, and the effect on the arterioles is the alpha effect. So, so now I'm going to ask two more of your classmates to introduce the topic of what is being described as short-term control and what is meant by long-term control. So please welcome Samuel and Chinta, who will give us a bit of introduction to this.
Hello everyone, thank you Prof. Cheng and all of the lecture in this place and all of the friends who have attended in this room. This opportunity, nice to meet you all. Hope you all in a good condition. Today, me and Chinta, maybe Chinta can say hi.
Hi everyone, nice to meet you all.
I'm going to give an introduction about what we are going to discuss, the next topic about the regulation of the blood pressure. Maybe I will share screen my presentation. Okay. Did you know how the regulation of the blood pressure in our body, Chinta?
Yes, Sam, it's all about the short-term and long-term regulation. Have you heard it before?
Yes, I did. But how you understand the short-term and the long-term regulation to control the blood pressure?
Well, for the short-term, it refers to rapid responses, and this will involve the rapid neural reflexes like baroreceptor mechanism. You have heard, right, for the baroreceptor mechanism?
Yes, sure, I did. For the baroreceptor mechanism is sort of mechanism that naturally adapted for the blood pressure in our body. So it's basically a feedback mechanism to reach a homeostasis of the blood pressure.
Well, you're right. When the blood pressure level in high condition, it will tell the heart to make the heart rate decrease, and also the blood pressure will decrease. And the low blood pressure, it will tell the heart to increase the heart rate and resulting the increases of the blood pressure.
Yeah, how about the long-term regulation of the blood pressure? Is it independent of neural mechanism?
Not exactly, Sam. The long term reflects the restoration of blood volume that will take a much longer time than the neural responses, and the kidneys are the key organ that maintain blood volume.
Oh wow, I will very interested for know more about how the kidney control the blood volume. No kidding. So our kidney are not merely executory organs.
The kidneys indirectly regulate blood volume by regulating the sodium balance in the body. After this, Prof. Cheng will also explain to us about the kidneys as controlling the blood pressure.
Yeah, you're right. It's very exciting. I hope everyone in this room still keep up the spirit to hear more about the kidney that can control the blood pressure. Thank you.
Thank you, Samuel and Chinta, for that introduction. So one of the points they made is that rapid control is very fast. It involves neural mechanism, and the long term involves blood volume, which is lower but very effective through the sodium balance control. So, so what we have heard so far seems to be quite basic but essential. So things are going to get more complicated now. So I normally tell my students, fasten your seatbelt because we're going to go into more detailed cardiovascular physiology as well as renal physiology in looking at the neuroendocrine mechanism of the integrated cardiorenal control of blood pressure. Okay, let me continue. Okay, so you see a playing card here. So sometimes I try to play with cards, and of course we think of cardiology. So this is my own version of cardology. You know, you can innovate and create and try to make things more interesting for students. So blood pressure control, this is the basic equation we consider. So the cardiac output component obviously affected by both nerves, sympathetic nerves, as well as hormones, the sympato, adrenal, medullary axis. And obviously, this is a function of the arterioles where the total peripheral resistance can be regulated. Now, as the students just said, the rapid control is obviously neural. It involves baroreflex, and the main effector will be sympathetic activity. All students can know this very well. They'll say that sympathetic will then increase heart rate, increase contractility, increase vasoconstriction, as well as increase venoconstriction. That will also improve the venous return. Now, in the control of the long-term control, we are talking about control indirectly through the control of total body sodium. Because by controlling total body sodium, you are indirectly maintaining blood volume. And whenever blood volume changes, the blood pressure will change. So this is in the region of the kidney. So we call this kidney land physiology. Sounds like Disneyland. So let me show you another physiometric diagram from my book. It's a combination of physiology and geometry, but expressed in a diagram to organize simple, small amount of physiology information to highlight key concept. So this is the what we said. The long-term control involves controlling volume of the extracellular fluid, because blood volume is part of extracellular fluid volume. And so how the sodium balance affects blood pressure is indirectly through its effect on the volume. Okay, so that is why there is certain link between dietary sodium and blood pressure. And one of the major pathways is obviously through the effect of total body sodium on ECF volume and also blood volume. So let me continue. So control of blood volume, which is long-term control of blood pressure, is via regulating sodium balance or total body sodium, because this is the main determinant of the ECF volume. And I think students will know this very well now, that this involves a family of hormones called the renin, angiotensin, aldosterone system. So this is where the other hormones now come in. At the very beginning, I mentioned that you have 4 different chemical type of hormones, and these two, this one is a steroid hormone, this is a peptide hormone. Okay, and activation of this system always conserve sodium or decrease urinary sodium excretion. So what this means is that whenever your blood volume drops, you will always activate the renin angiotensin system. And then because the final hormone here is aldosterone, you will decrease the sodium excretion. So as I think Samuel said that, he said something like, the kidneys are not merely excretory organs. And this is true, because the amount of sodium you excrete in your urine is actually a compensatory response to the sodium balance. So every time you go to the toilet, you are actually performing homeostatic work. Yeah, the amount of sodium you excrete is in response to body fluid changes in the body. And this involves, again, we come back to the nerve, we're talking about neuroendocrine, because the renal sympathetic nerves is one of the factors that increases the secretion of renin. Okay, so you think about the sympathetic nerves as being involved in baroreflex, but every time you increase sympathetic activity during a baroreflex, you already also increase the renal sympathetic activity. And the cells that secrete renin, the juxtaglomerular cells, are innervated by the renal sympathetic nerves. So we'll come to this in a short while, but just to mention that when we talk about the short-term and long-term pressure control, it is not a separate sequential event, because already you can get secretion of renin every time you have a baroreflex increase in sympathetic activity. So whenever sympathetic activity increases, you are also saying that the renal sympathetic response has already started. Now I'm going to move on to the next slide, which is just for the sake of completeness, and that is the renin control of long-term blood volume blood pressure is affected by renal sympathetic nerves. And this is just one of the pathway for the increase in the secretion of renin, an important family of hormones that involve angiotensin and aldosterone, in order to maintain sodium balance as well as blood volume control. So the next slide is the summary of the three main pathways for renin secretion, besides the stimulation by the renal sympathetic nerves. Okay, so here we are. So let me take you through this slowly. So right at the top is a decrease in the plasma volume or the blood volume. Okay. Now, without looking at the one in the middle, I want you to look right at the bottom here. So every time you have a change in the blood volume, the final effect will always be to change the sodium excretion, because the sodium balance affects volume control. So if you are hypovolemic for whatever reason, whether diarrhea, vomiting, or even blood donation, you will always have a compensatory decrease in sodium excretion, because the body is trying to restore your total body sodium in order to restore your blood volume. And obviously, if you want to restore sodium, you have more aldosterone in order to reabsorb more sodium. And that obviously comes from angiotensin 2, and then that comes from renin. So as we just said in the last slide, every time you are in negative sodium balance or hypovolemia, you will always activate renin. Okay, so what are the three ways? One, as we just mentioned here, this is all abbreviation, renal sympathetic nerve, RSN. It stimulates the JG cells to release renin. Now, the second mechanism works through something I think all students know, and this is the macula densa. MACD is not McDonald, macula densa. So there is a signal, and this is a little bit more complex. Every time you have hypovolemia, there will eventually be a signal that arrives at the macula densa to also increase renin. So increase in renal sympathetic nerve, increase in the paracrine signal from the macula densa to affect increased secretion. And then the third pathway, which at the same time also increases renin, is a direct sensing mechanism. So this shows you that when the volume drops, the pressure drops. And this is renal perfusion pressure, or just renal arterial pressure. So here is a set of receptors which are actually present on your afferent renal arteriole, that actually senses, there you are, direct sensing of the renal arterial perfusion pressure. And these receptors are also called baroreceptors. They are given the name intrarenal baroreceptor because the receptors are found in the kidney at the afferent arteriole. So the intrarenal baroreceptors will directly sense the drop in the renal perfusion pressure, and that also will increase renin secretion. So all three pathways increases renin when you have a drop in the volume, and then that helps to increase aldosterone and conserve the sodium, and eventually over a couple of days you will restore the volume and maintain what is known as the long-term control of blood pressure. So again, let me show you in this physiometric way. So the sodium involved in blood pressure control. So you have blood pressure is CO times TPR. So how does total body sodium affects blood pressure? This is indirectly through affecting volume. And this is obviously under the renal control of total body sodium affecting volume. And whenever you change the volume, you will affect the cardiac output, because greater blood volume will also mean greater volume of circulating blood, greater venous return, and greater cardiac output. So, just to highlight the point, short-term and long-term mechanisms of blood pressure regulation and compensation are not sequential, separate events. The neurohormonal mechanisms are integrated. And I think part of the problem that students sometimes think about them separately is because the cardiovascular baroreceptor mechanisms are sometimes taught 2 months before the renal mechanism, which controls long term. And so there may be a failure to integrate the cardio-renal mechanism in the control of blood pressure. So, so I have this picture. This is obviously just after Chinese New Year. So this is the integrated picture of how you should understand whole body physiology. This is the disintegrated, fragmented, sequential understanding of whole body physiology. So let me elaborate here. Sympathetic nerve are involved in short term, and let me introduce now something called the intermediate term control of blood pressure, and obviously the long term. So short term is rapid baroreflex. Long term involves volume control, and obviously that involves sodium balance. So we already mentioned that the sympathetic nerves can already increase the renin angiotensin system. And so every time you get the rapid baroreflex, the renal sympathetic nerves already begins to increase renin secretion. So it's not a sequential separate event. Now let me turn to this intermediate event, sometimes called the transcapillary fluid shift. And this is because the sympathetic nerves, obviously, when you have hypovolemia, will vasoconstrict the arterioles, right? And so when it vasoconstricts the arterioles, I mentioned right at the start that there is a downstream capillary effect in reducing the hydrostatic pressure in the capillary. And because of that, there is now a shift in the Starling's forces at the capillary. And this actually benefits the person because it produces what is known as a transcapillary shift, whereby more fluid shifts now from the interstitial fluid into the vascular volume. And so temporarily, this helps to conserve the vascular volume. Let me show this to you in a diagram. So this is now this is a tooth that I inherited when I was in Jakarta. A few years ago, we actually had the first national interdental school physiology event. And part of the event was the students obviously also had a competition in modeling. So I managed to get this gift back. Okay, so here you are. So vasoconstriction by the sympathetic nerve will always reduce your hydrostatic capillary pressure. Now the oncotic pressure is unchanged, and because of the balance of these two forces have now changed, you actually favor more reabsorption of fluid, and that helps to temporarily conserve plasma volume before the renin angiotensin system takes effect. Okay, so this is also quite useful. So the last point for this overview talk is something quite important, and that is we are thinking about the central homeostatic vasoconstrictor response occurring at the same time. It's a very long statement, complemented by a concurrent simultaneous local vasodilation response. And this is in order to maintain adequate driving pressure to both the essential organs, the heart and the brain. So listen as we invite the last group of students among your classmates in Airlangga to introduce this topic. So let me invite Sasha, Seka, and Maldiva to present now.
Hello everyone. Good morning. My name is Maudi. I hope we're all in good condition. Well, thank you so much, Professor Cheng and the other professor, Doctor, my senior, and my friends. Thanks for this cool and great opportunity to help Prof. Cheng's lecture. So I'm not alone here. I have Sasha and Amal is my partner today. Are you there, guys?
Hello, Maudi. Yes, I'm here. Hello, everyone. Good morning. I'm Sasha. Nice to meet you all.
Well, hello, Maudi. Yes, I'm here. Well, hello, everyone. Good morning. Nice to meet you all. So the next topic introduction is going to be presented by Maudi, Sasha, and me, and our friend Danny will help to screen share it.
Hey guys, I'm Amel and I want to ask some questions to you guys. Let's discuss physiology topic about total peripheral resistance.
Hi Amel, I'm Sasha.
Good to know you guys, my name is Maudi.
Does the total peripheral resistance or TPR response by sympathetic nerve include all arterioles?
The T for total in TPR may give the wrong impression, but certainly it is a selective total. This means that the arterioles at the essential organs of heart and brain are spared as the vasoconstriction response of coronary and cerebral arterioles. When baroreflex is activated during hypovolemia, will worsen the blood flow to the heart and brain.
Oh, that makes a lot of physiologic sense. So, the arterioles in non-essential organs will participate in the TPR compensatory responses.
Yes, Sasha, you are right. The splanchnic, cutaneous, and renal arterioles vasoconstrict with sympathetic action to raise the TPR when hypovolemia leads to hypotension.
Thank you for the answer, Maudi and Sasha. I have another question. So, the vascular resistance at the coronary cerebral circulations are unchanged?
I think no. There is, at the same time, local vasodilation by metabolites at the heart and brain, so that the central homeostatic vasoconstrictor response to raised blood pressure is complemented by a concurrent local vasodilation to ensure adequate coronary and cerebral perfusion.
Thank you, Sasha and Modiva. So this is actually an essential concept that that among my students in University Malaya, very often they get a bit confused between the opposite central vasoconstrictor response, and at the same time, you have a vasodilatory response at the two essential organs in order to maintain the adequate blood flow to these essential organs. So I'm going to elaborate this slightly here. So let me just go back. Okay, I like to show this picture of the giraffe because the basic concept is that in blood pressure regulation, perhaps one of the most important reasons to maintain a blood pressure is to maintain a blood flow to the brain, cerebral circulation. Because in most of us, we spend most of our walking hours in the erect position. So there is a need to control blood pressure. So if you think about the giraffe, next time you go to the zoo, you can imagine that the blood pressure control for the giraffe is even more efficient because the giraffe brain or the head is even further away from its heart. And if you think of the dinosaur, Jurassic Park, the blood pressure regulation must be even more important. There was an article in the medical journal Lancet that postulate that perhaps in the dinosaur that roamed the earth, there may be a series of cardiac pumps in order to maintain sufficient blood pressure to the brain. Okay, so the point that students was making is that in the control of blood pressure, when we talk about a baroreflex response by increasing TPR, that total sometimes gives the wrong picture that it involves all the arterioles. But certainly for the brain and the heart, the total is not involved here. You can constrict the kidney arterioles, you can constrict the splanchnic, you can constrict the skin, cutaneous, because these are non-essential organs. But the brain and the heart has to maintain a constant blood flow. And in fact, for the heart, during hypovolemia, it is actually more active because of the baroreflex, increases stroke volume, increases heart rate. And so the coronary blood flow actually during hypovolemia is actually greater. So this is the complementary picture, which I illustrated again in this Hwee geometric diagram. So you have, if you have decreased blood volume, you have a baroreflex that will generate increased TPR in order to maintain pressure. At the same time, at the heart and at the brain, you have local metabolite that will vasodilate the blood vessel in order to maintain sufficient supply to the heart. And you can add on here also to the neurons in the brain. Okay. So the next few slides, I'm going to just now summarize what we've been talking about. Our focus this morning is on the neuroendocrine integrated control of cardiorenal mechanism. So I've drawn this as a doodle. Sorry, here you are. So this is your adrenal gland with the adrenal medulla here. So the black lines represent sympathetic nerves, the major neural component. So here you are in the sympatho-adrenal medullary axis. Obviously, you can increase the adrenaline, catecholamines, and this will increase the heart rate and stroke volume. Now, the sympathetic nerves, as we just seen, also innervates the juxtaglomerular cells in the kidney, and this releases renin, which subsequently produces angiotensin II, and that stimulates the adrenal cortex to increase aldosterone. And we've just said that the aldosterone is very important to maintain total body sodium or blood volume. Now, the adrenal gland has another hormone that is important in the overall blood pressure control. And this is the hormone cortisol, another steroid hormone. Now, cortisol is important not because it is a vasoconstrictor or vasodilator. Cortisol is important in order to make your blood vessel and especially your arterioles become more responsive to vasoactive agent. And I think we know that in the hypothalamo-pituitary axis, the CRH, corticotrophin releasing hormone, affects ACTH from the pituitary, and that affects cortisol. And if you think about CRH being a hypothalamic hormone, CRH is also a neurohormone. Okay, so this is the overall picture. Now let me just now focus in the next slide on the sympathetic nerves, since this is a major effector mechanism in overall blood pressure control. So this is another doodle. So so here is the sympathetic. Okay, so here is the adrenal medulla, which obviously produces your adrenaline, and then at the afferent arteriole, this is the location of your JG cells that secrete renin, and that produces your angiotensin II and aldosterone. And then by constricting the afferent arteriole, actually this is part of maintaining total peripheral resistance. Remember we said that not all arterioles will vasoconstrict when you have a barrel reflex, but certainly the renal arterioles will vasoconstrict and contribute to the TPL. Okay, and then the last effect is that by vasoconstricting the renal arterioles, you are actually decreasing temporarily the glomerular filtration rate, and this has an indirect effect in reducing the filtered sodium load. So this goes back again to the fact that if you want to maintain volume, you have to excrete less sodium. So this is already what is known as the renal long-term control of total body sodium, and how that controls your ECF volume and blood volume. So you see here that the sympathetic nerves are involved in various ways through the adrenal medulla and through the kidney and the afferent arteriole by these three pathways in order to affect the overall blood volume, blood pressure control. Yeah. So this picture here, if you can see, might be blocked by the screen, is actually a picture of my grandson that was just born. I'll tell you why I'm showing his picture here. He's just turned 7.5 months towards the end. So another summary. So for students who are trying to remember all the hormones, so coincidentally, I've been reading about the Ayalanga, interesting history. Ayalanga obviously starts with the letter A. So now it's quite easy to summarize some of the main factors involved in the neuroendocrine control of blood pressure. A, first of all, stands for the autonomic sympathetic nerves. Okay, and we've talked about the sympathetic medullary axis, which also involves adrenaline. And then we talked about angiotensin 2, aldosterone, angiotensin 2 stimulating aldosterone. And then we will also talk about the antidiuretic hormone. Now, antidiuretic hormone, I think for most of us, the first thing that comes to mind is osmoregulation. But I think you will remember from your endocrine lecture that the ADH vasopressin, which is a neurohormone, is also affected by changes in the volume. So there's also a separate volume sensing through the afferent nerves that can also affect ADH secretion. Now, what is this R here, which we haven't mentioned? R here is the sensation of thirst. Okay. The sensation of thirst, obviously, as long as you are still conscious, is also part of volume control. And the last A is in the opposite situation where you are in positive sodium balance or hypervolemia. This series of hormones can be secreted in order to restore both the sodium balance and the blood volume. So let me show you one slide about ADH here that I just mentioned, that the volume sensors or receptors can affect ADH secretion. Okay, this is the one. So here you are, ADH secretion. So as you change the volume, there are a series of volume sensors, and that also involves your baroreceptors. Baroreceptors are simply volume sensors because blood volume affects blood pressure. So under the general category of volume sensing, you have the baroreceptors. You also have the volume receptors on the low pressure side of the circulation. And sometimes they just call them volume receptors. So what we're saying is that as your volume drops, both your baroreceptors and your volume receptors, as well as volume sensors in the cardiac chamber, the atrial volume receptors, can be stimulated to affect vasopressin or ADH secretion. And so by conserving water, ADH is also part of the blood volume, blood pressure control. And just looking at the name, vasopressin, the other name for ADH, it tells you straight away that ADH or vasopressin is also a potent vasoconstrictor. Okay, so let me summarize. Yeah, I wanted to show you that because this is a talk to dental students, that in the recent weeks, my grandson just began to sprout some teeth. So this is a magnified picture. So the first two teeth. Okay, let me mention something now about angiotensin 2. Angiotensin 2, obviously, the main action is to stimulate aldosterone. This is part of the long-term blood volume, blood pressure control. But angiotensin 2 also enhances the sympathetic nerve in the control of blood volume and blood pressure. For example, angiotensin 2 is a strong vasoconstrictor. So by increasing the TPL, it also contributes to blood pressure control. It also contributes to a reduction in the filtered sodium load because vasoconstriction of inner arterioles will reduce the filtered sodium load. It also directly increases sodium reabsorption at the nephron. In other words, what we're saying here is that there are actually angiotensin 2 receptors at the proximal convoluted tubule that will increase sodium reabsorption. And to link this to ADH, angiotensin 2 is a short peptide. It can enter the brain and stimulate ADH secretion. And added to that, angiotensin 2 also stimulates the sensation of thirst. So I just have two more slides left to summarize. So in the overall understanding of the neuroendocrine control of blood volume and blood pressure, obviously we need to consider the homeostatic loop. And so every time your blood volume or blood pressure drops, there must be volume sensing. Okay, so the last slide, this is again a little bit of history and the famous statue. Volume sensors, so let me repeat myself. Volume sensors are categorized under three groups. One is actually your baroreceptor, mentioned here. The second group is actually your volume receptor, just mentioned. These are in your large veins, as well as in your pulmonary vessels, as well as in the atrial chamber. Okay, and then the third group of volume sensors is at the bottom here, the intrarenal baroreceptor, present at your afferent arteriole. So in the overall picture, whenever the volume changes, there will be a neural reflex from the first two groups that will affect an increase in sympathetic response. And then sympathetic activity, as we saw in the previous slide, will produce its many effects. And then the afferent impulses also affects ADH secretion. The afferent impulses from your arterial and volume receptors also affect the thirst sensation. So you can now begin to integrate in a more interesting, complex way. Now, the direct sensing for the volume sensors would involve what we just mentioned, the intrarenal baroreceptors. So you remember that one of the pathways, the direct sensing, will affect the secretion of renin. Now, in the opposite situation, if there is hypervolemia, volume expansion, the volume receptors direct sensing can now increase the secretion of the atrial natriuretic peptide in order to produce, in this case, increased excretion of sodium. So I hope that this big picture, very brief big picture of the neuroendocrine mechanism of integrated cardiorenal mechanism of blood pressure control would be useful. And as I said, I will send this set of slides to Dr. Aksa to freely distribute to all of you as a reference. So let me thank again the students who have contributed to this talk. This seems to be a good way to provide a bridge of engagement between the speaker and to a new group of students. So let me thank again this should be 10 students. One of them was missing that evening. We've been discussing this for at least 2 times here. Okay, Samuel, Yasmin, Ramadani, Sasha, Cinta, Seka, Patricia, Josephine, Maldiva, and I think Rena was missing that evening. Thank you very much for listening.
Thank you, Professor Cheng, for the interesting presentation. I believe it will bring a great benefit for us, especially for the student, to make them the better understanding for the physiological course in Universitas Erlangga. Now we come to the discussion session. Please, if you have any question, you can ask to Professor Cheng, or you can write to the chat area, to the chatting section. For the student, do you have any question? Professor Cheng, we recognize 2 kind of hormones that have similar effect, but reabsorb the water, promote reabsorb the water, and finally increase the blood pressure. They are ADH and aldosterone. Yeah. In your opinion, which one have the stronger effect to increase the blood pressure and to reabsorb the water?
Yeah, so I think the perspective is that ADH is primarily the dominant hormone involved in osmoregulation, control of osmolarity. But because it is also affected by volume, when the volume does drop quite significantly, it's not as potent a stimulus as for changes in osmolarity, but it also will increase ADH. So, so obviously, ADH being vasopressin, that's the other name, can also produce vasoconstriction. I'm not a clinician, but I don't know whether in certain situations, pharmacological doses of ADH are also given in order to try to raise the TPR. Yeah. So I have to check on this. But aldosterone action is slower, obviously, because it affects sodium balance, which then recovers the total body volume and ECG volume. So this is under long-term control, so in a sense they are quite separate mechanism. Aldosterone is involved in volume control, and ADH is involved in osmoregulation. But of course, when volume changes significantly, it can also trigger the vasopressin response.
So which is the more responsible for the blood pressure elevation?
If you have a drop in the hypovolemia, both, if you measure the plasma level of both, you will see an increase in both. So in a sense, they are part of the whole spectrum of neuroendocrine responses. So I can't really say which is more potent because both have slightly different function.
Yes, okay, thank you.
Because
Prof. Cheng.
ADH is generally considered as under control of water balance.
Yes.
And aldosterone as under sodium balance. But of course, there is some relationship.
And for sure, they have a different, location in the renal tubule where BDH have action and where aldosterone have action. They have different location in the renal tubule, right?
No, actually, I think students will notice that the target cell for aldosterone and ADH is actually the same cell at the principal cell of the collecting duct. This is something quite interesting, yeah. So that means the receptors for aldosterone and the receptors for ADH are present in the same type of collecting cell. Yeah, so this is quite it's an interesting point, yeah.
Yeah. If there is no other question, bagaimana ini MC? Dr. Yosi, should I close the meeting or shall we invite him to give the certificate?
Mr. Chairperson, before we close this first section, there will be a delivered of certificate virtually that will be delivered by the Dean of Dental Medicine Faculty, Universitas Airlangga, Dr. Agung Sosiawan, Dr. Gigi Kemkes, please. Maybe we should share a screen first for the certificate.
Thank you. Yeah.
Dr. Agung, please.
Or Vice Dean, maybe.
I will check first. Oh, he's probably not still occupied. Could be represented by other committee, perhaps. Maybe represented by the chairperson, please. It's okay. As a part of the committee, please, sir.
Okay, thank you, Dr. Yosi. Professor Cheng, herewith, I give you the certificate of participation. We would like to thank for your talk to share your knowledge to our faculty. I believe your knowledge will bring many benefits to our students, in particular, to make them to have a better understanding of the subject. Again, thank you for Cheng.
Thank you.
I'm looking forward the more continuous lecture in the future.
Thank you. Thank you.
Is that Dr. Yosi?
Thank you very much.
So sorry, Dr. Yosi, maybe
there will be the delivered of the certificate to the chairperson, if I may represent the committee to deliver it virtually for the certificate to Dr. Aksa.
So maybe I will.
Okay, Dr. Barita, please.
Yeah, okay, I will take part for this. Dr. Aksa, thank you very much for your kindness as a moderator for today's seminar, and also for Prof. Cheng, thank you very much for your time and also for your presentation. Hopefully we can meet again in another seminar. Once again, thank you very much, Prof. Cheng and also Dr. Aksa.
Thank you. Right.
Thank you very much.